Ever catch yourself feeling unexpectedly winded, maybe just climbing stairs or just generally worn out and you can't quite figure it out why? Sometimes we shrug these things off, but occasionally they're little clues to something more significant.
Mhm.
Today, we're doing a deep dive into a condition that can crop up because of lung problems. Cor Pulmonale.
That's right. And fundamentally, cor pulmonale is when the right side of your heart gets bigger and weaker.
Hmm.
It happens because of high blood pressure in the lungs. That's what we call pulmonary hypertension.
Okay.
So think of the right ventricle, the part of the heart pumping blood to the lungs. It's constantly pushing against this higher pressure, this resistance, and well, it gets bigger, hypertrophies, and eventually it just struggles to keep up. It's a specific type of heart disease that actually starts from lung issues, pulmonary heart disease.
Okay, so the heart's right side is straining because the lung pressure is too high. Now, what causes that pressure to build up? Our sources for today, these really helpful revision notes, say the main thing is pulmonary hypertension, and that itself can be kicked off by a whole range of lung conditions.
Yeah, it's actually quite surprising how many different things can lead to this. And the notes are absolutely right. COPD, chronic obstructive pulmonary disease, is definitely the most common cause we encounter, particularly here in the UK.
Right, COPD is the big one.
Mhm.
But to help us sort of get a handle on the others, our notes group them quite neatly. First up, we've got the respiratory causes, which, makes sense.
hmm
This category includes things like severe chronic asthma, pulmonary fibrosis, that's scarring in the lungs, makes them stiff obstructive sleep apnea, bronchiectasis, where the airways get abnormally wide, and even things like lung resection, if someone's had a chunk of their lung removed. You can see how that might affect pressures.
Absolutely. I mean, any chronic condition that messes with your oxygen levels or just the way the lungs work mechanically can contribute.
Hmm.
Then we have the vascular causes, which are more about the blood vessels themselves inside the lungs.
Yes, the vascular group. That includes pulmonary emboli blood clots, blocking lung arteries, pulmonary vasculitis, which is inflammation of those vessels, and even something called primary pulmonary hypertension, where the pressure is high but without an obvious lung cause.
Yeah, that's a distinct condition in itself.
And interestingly, sickle cell disease and even cerebrovascular disease, like a stroke, are listed here too, which maybe aren't the first things you'd think of for lung pressure.
No, definitely not. And it really shows how interconnected things are in the body. With sickle cell, for instance, the shape of the red blood cells can actually cause tiny blockages in the lungs' small vessels.
Ah, oh,
And with stroke, it's often a bit more indirect, maybe affecting breathing control centers in the brain, perhaps leading into issues like sleep apnea downstream. Then there's a third group, MSK and structural causes.
right, the MSK and structural group. This covers conditions like myasthenia gravis, motor neuron disease, polio, things that weaken the breathing muscles, but also skeletal problems like severe kyphosis or scoliosis, a type of chest surgery called thoracoplasty, and even enlarged adenoids in children. That last one's a good reminder this isn't just an older adult issue.
Exactly right. Anything that really restricts breathing mechanics over the long term can put that strain on the right heart. Uh, Maybe a way to remember these categories. How about really vexing matters? R for respiratory, V for vascular, M for musculoskeletal and structural.
Really vexing matters. Okay, I like that. It helps group them. So, building on the causes, who's most likely to develop this? What are the main risk factors our notes point out?
Well, as you'd expect, the risk factors really just mirror the causes. So chronic lung diseases, especially COPD, are top of the list. Sleep apnea is a big one too. Also, living at high altitudes where the air has less oxygen naturally puts a sustained strain on those pulmonary arteries. And finally, certain congenital heart defects that affect blood flow into the lungs can increase the risk as well.
So it really boils down to anything causing long-term stress on the lung circulation, leading to that increased resistance. Which brings us nicely to the pathophysiology. How does this actually unfold inside the body?
Yeah, the sequence is pretty logical. As the notes lay out, you start with a chronic lung condition.
Yeah.
That leads to pulmonary hypertension, high pressure in the lung arteries.
Okay.
This increased pressure means the right ventricle has to work much harder to push blood through the lungs. Over time, this extra workload causes the right ventricle muscle to thicken and enlarge. That's hypertrophy.
Right.
But eventually, if the underlying issue isn't addressed, the muscle just can't compensate anymore and it starts to fail.
That's right.
Ventricular failure.
And the notes also mention hypoxia and hypocapnia, low oxygen, and high CO2, which are common in these lung diseases. How do they fit into the picture?
Well, this is a crucial part. Low oxygen and also high CO2 to some extent actually triggers the small arteries in the lungs to constrict, to tighten up.
Oh, right.
This vasoconstriction makes it even harder for blood to flow through the lungs, which pushes the pulmonary pressure even higher, worsening the pulmonary hypertension. So it kind of becomes this vicious cycle, unfortunately, speeding up the strain on the right ventricle.
Okay, that makes sense. A struggling heart, high lung pressure, and the body's own response actually making things tougher. So if someone comes in with symptoms that might suggest this, what else could be going on? What are the key differential diagnoses?
Good question. The main things you need to think about and rule out are left heart failure, failure of the other side of the heart. Then there's chronic thromboembolic pulmonary hypertension, or CTEP.
That's the one from old blood clots.
Exactly, persistent clots causing high pressure.
Uh-huh.
And then there's primary pulmonary hypertension, where you have the high lung pressure,
Huh.
but without an identifiable heart or lung cause. Distinguishing these is really important because the underlying reasons and therefore the treatments are quite different.
Okay, yeah. You wouldn't treat heart failure caused by a lung problem the same way as heart failure from, say, a heart attack affecting the left side.
Precisely.
So getting the diagnosis right is key. What about how common this is? What's the epidemiology look like?
Well, as the notes say, the prevalence of Cor Pulmonale is very closely tied to the prevalence of its underlying causes, particularly COPD. So wherever you see a lot of chronic lung disease, you'll inevitably see more Cor Pulmonale. It does tend to be more common in older adults and those with a significant smoking history or other chronic lung issues, again, reflecting those root causes.
Okay, that paints a picture. Now let's get to the clinical features. What signs and symptoms should make us suspect Cor Pulmonale?
The key thing, as the notes really stress, is that the main features are those of right-sided heart failure. Think about it. If the right ventricle can't pump blood effectively forward to the lungs, then blood is going to back up behind it into the body's main circulation.
Right, the systemic circulation. So victim-wise.
Well, symptoms often include shortness of breath, dyspnea, although that can be tricky because the underlying lung disease often causes that too.
Sure.
Fatigue is very common. The heart just isn't pumping efficiently. Syncope, which is fainting or passing out, can happen, particularly when exerting oneself. And in more advanced stages, you might see cyanosis, that bluish tinge to the skin and lips from low oxygen.
And what about the signs we might pick up on examination?
On examination, you might find tachycardia, a fast heart rate. Syncope, again, could be a sign as well as a symptom. A really classic sign is a raised JVP jugular venous pressure, which you can see as a pulsing in the neck veins. Sometimes you see prominent A and V waves within that pulse. You might also feel an impulse or lift over the right ventricle when you place your hand on the chest. That's called an RV heave. Listening to the heart, you might hear a loud second heart sound, specifically the pulmonary component, P2, which points towards pulmonary hypertension.
And our notes mentioned a couple of murmurs, too.
Yes, potentially a pansystolic murmur. That's a murmur throughout the heartbeat due to the tricuspid valve leaking under pressure. And sometimes a Graham-Steele murmur, which is an early diastolic murmur caused by the pulmonary valve leaking.
Wow, okay. Lots to listen for.
And then there are the signs of fluid backing up. Hepatomegaly, an enlarged liver because it's congested with blood, sometimes ascites, which is fluid in the abdomen, and peripheral edema swelling, usually in the legs and ankles.
Okay, quite a collection of signs. The notes suggested a mnemonic for some of those right-sided failure signs. Just remember liver edema, J for JVP, R for RV heave, L for liver enlargement, and E for edema.
That's a good one. Helps tie some of the key physical signs together. So if we suspect Cor Pulmonale based on the history in these signs, what's the systematic approach to investigations?
Right. The notes lay out a clear pathway. First, bloods. A full blood count, or FBC, might show raised hemoglobin and hematocrit if the body's been making extra red blood cells to compensate for chronic low oxygen, that's secondary polycythemia. And BNP levels B-type natriuretic peptide are likely to be up, as that's a marker released when the heart muscle is stretched and strained, indicating heart failure.
Definitely. After bloods, an arterial blood gas, ABG, is critical. This gives us direct measurements of oxygen and carbon dioxide in the arterial blood, showing us if there's hypoxia and whether it's type 1 or type 2 respiratory failure. Type 2 involves high CO2.
Then the ECG, the heart tracing. Classic findings suggestive of Cor Pulmonale include P pulmonale, tall, peaked P waves in certain leads, often linked to right atrial enlargement. Easy to remember. P for pulmonale, P for pulmonary.
Nice link.
You might also see right axis deviation on the ECG, showing the heart's electrical activity shifting rightwards, and signs of right ventricular hypertrophy or strain patterns.
Following the ECG, a chest X-ray, this might show visible enlargement of the right atrium and ventricle, and the pulmonary arteries might look prominent, again suggesting high pressure. Crucially, the X-ray can also give clues about the underlying lung disease, like signs of COPD or fibrosis.
But the real key investigation, according to our notes, the main diagnostic tool, is echocardiography.
Absolutely. The echo and ultrasound of the heart is invaluable. It lets us directly visualize the right ventricle, assess its size and how well it's pumping, and we can also get good estimates of the pressure in the pulmonary artery.
So it really confirms the structural and functional changes.
Exactly. And finally, pulmonary function tests, PFTs, or lung function tests. These are vital for diagnosing and assessing the severity of the underlying lung disease, which, as we keep saying, is usually the root of the problem.
Okay, so diagnose the lung issue, assess the heart damage. That leads logically to management. And the notes are very clear here. The absolute priority is to treat the underlying cause.
That's the cornerstone. If it's COPD causing it, optimize the COPD management. If it's sleep apnea, treat that with CPAP. If there's an infection triggering an exacerbation, treat the infection. Reducing that pulmonary hypertension is the goal.
Makes sense. And part of that is treating any respiratory failure.
Yes, definitely. Oxygen therapy is crucial for hypoxia, for low oxygen levels. But you need to be careful, especially in some COPD patients who retain CO2, monitoring them closely. For those with chronic severe hypoxemia from COPD, long-term oxygen therapy, LTOT, has actually been shown to improve survival.
Okay, so supporting breathing is key. Then what about treating the cardiac failure itself, the struggling right heart?
For the heart failure component, diuretics like furosemide are really important to manage fluid overload, the edema, the liver congestion. But you have to monitor kidney function and electrolytes carefully when using them. In rare cases, if the polycythemia gets extreme, say a hematocrit over 55%, venesection, basically removing some blood, might be considered to reduce blood thickness. And for very severe cases, especially in younger patients, heart-lung transplantation might be the only remaining option, though it's obviously a major undertaking.
Are there other specific drugs mentioned?
Yes, the notes mention a couple of other possibilities. Sometimes drugs specifically aimed at lowering pulmonary artery pressure, like phosphodiesterase 5 inhibitors, sildenafil as an example, might be used, though often under specialist guidance. And anticoagulation, blood thinners, might be necessary if blood clots are involved or if the patient is at high risk, for example, due to severe right heart failure or atrial fibrillation.
So it's a really multifaceted approach. Manage the lungs, manage the fluids, support the heart, and sometimes use specific drugs for the pulmonary pressure or clotting risk. Given all that, what's the typical outlook? What's the prognosis?
Unfortunately, the prognosis for established cor pulmonale is often quite poor. As the notes point out, it carries significant mortality. Something like 50% of patients might die within 5 years of diagnosis.
Wow.
Yeah, it's serious. But, and this is important, the prognosis really depends heavily on the specific underlying cause, how bad the pulmonary hypertension is, and how much the right ventricle function has deteriorated. Early diagnosis and, crucially, effective management of that underlying cause can definitely improve outcomes and quality of life. It's not uniformly bleak, but it is a serious condition.
Understood. And finally, what are the main complications we need to be aware of?
The notes list several key ones. Obviously, progressive right heart failure itself is the major complication. Arrhythmias, irregular heart rhythms, particularly atrial fibrillation, are quite common. There's also an increased risk of venous thromboembolism, blood clots forming in the veins, like DVTs or PEs. And that chronic back pressure of blood can lead to hepatic congestion, where the liver gets swollen and doesn't function properly.
Okay, so a really serious condition stemming from lung problems with significant knock-on effects. Just to quickly recap the key points from our deep dive on Cor Pulmonale. It's essentially right ventricular enlargement and failure that happens because of high pressure in the lungs, the pulmonary hypertension. This is most often driven by COPD, but lots of other lung, vascular, and structural issues can cause it. The signs and symptoms are mainly those of right-sided heart failure. Echocardiography is the key test for seeing the heart changes and estimating the pressure. And management really hinges on treating that underlying cause aggressively alongside managing the heart failure symptoms.
Absolutely. I think it really highlights just how intimately connected our heart and lungs are. You know, a chronic problem in one system can have such a profound detrimental effect on the other. It's a stark reminder of that interconnectedness.
Definitely a powerful point to end on. We really hope this deep dive has helped solidify your understanding of Cor Pulmonale and made it a bit more memorable for revision. Do go back over the key points, maybe test yourself. And remember, for more high-yield resources tailored for your MSRA preparation, check out pastthemsra.com and also freemsra.com.